to another Kizer on the Couch session. We're into our fourth session now, and tonight will be particularly interesting, where probably Carlo and I will be the only two male participants. And Carlo and I are about to learn a hell of a lot about women's health and pelvic floor. But in order to give everybody just a couple more minutes to arrive, and also to give Hannah a little bit of insight about who she's going to talk to tonight, we've got a little poll that we would like to start with. So Carlo, who actually is a human being and does have a face, but just appears in these videos as a name, Carlo's about to kick off a poll that everybody can see. And that should pop up on your screen straight away. And have you had children? No, I haven't. And if you just go through and tick which is the most appropriate response to each of those questions, it'll give us, or give Hannah, a little bit of insight into who's listening this evening.
Good spot, Michael.
There's 4 questions there, so if you get to the first 2, just scroll down a little bit, and then you'll find the submit button down the bottom, and we'll leave that open for a couple of minutes just to allow everybody to answer those questions. But Hannah, this might be a little bit premature because I haven't even officially introduced you yet. But while everybody else is completing the poll, why and how have you developed such an interest in women's health and the pelvic floor?
You've just stolen my first slide, Tim.
Okay, I've got heaps of other questions. I've got heaps of other questions you want me to...
No, happily go there. So my interest, it's interesting actually, my interest really developed about 12 or 13 years ago when I did a women's health placement at King Edward Memorial Hospital in Perth, which is where I did my physio degree. And I really enjoyed working on the postnatal ward and in the continence clinic. And we were lucky enough to work alongside some of the gynecologists there and see quite a few surgeries at that point in time. So that really sparked a strong clinical interest. And then having sisters go through pregnancies and the challenges that they faced then sparked a personal interest as well. And then so my first job as a physio led me down women's health pathway. It was a part women's health, part just musculoskeletal role, and I loved that. And then I chose to continue that in the UK, and then have tried my best to keep a bit of a women's health caseload at Kizer. So it's a bit of a long-winded history.
So experience across 2 states and 2 countries.
Yes, yeah, I do. Yet to go down the route of my postgraduate. I've done some, APA courses and some further sort of PD, obviously, along the way. But I think the postgraduate women's health degree is probably the next step for me.
And so when did you say that starts? Next week or the week after?
I was thinking maybe August, the month before I'm due with my second would be a really good time to start.
I was going to say you'd have plenty of time. Well, speaking of time, and we might kick off. So,
okay.
Thank you everyone for coming. I'm going to briefly give an introduction to Hannah and tonight, and then I'm going to make myself scarce. But thank you very much for registering and for coming along. Hopefully you all find tonight's presentation really informative, and you can take away a lot of information. But there may come a point during the evening where you wish to ask a question. And when you do, down the bottom of your screen, you'll see a little Q&A function. And if you type your question in that Q&A function, then Carlo and I will have a look at that. And you might see my face pop up on screen, and I'll just put my hand up and catch Hannah's attention, and she'll be able to answer your question, hopefully live, And if we don't get to answer all of them as we go, then we'll certainly do our best to answer as many as we possibly can in the last 10 minutes, because Hannah should be finished by about 10 to 8. And we'll usually have quite a few questions there at the end. So that's the best way. If you need to ask anything, just use the Q&A function down the bottom. Otherwise, I'd like to introduce Hannah Finnigan, who's a senior physiotherapist at Kizer in Camberwell. As most of you have just heard, Hannah did her physiotherapy degree in Perth and has worked both in Australia and overseas. She has a particular interest in women's health and the pelvic floor, and also and I've spoken to Hannah about this many times, trying to debunk some of the myths and talk about the things that a lot of others don't want to talk about, because this isn't a small issue in Australian society. It's much more common than what people realise, and hopefully slowly we're starting to break some misconceptions and bring it into the more common vernacular. So Carlo, if you could finish the poll for me, please, then we can put those results up on the screen for everybody to read. So Hannah, do you get a copy of those? Can you see those on your screen?
I can see them now.
Perfect. So hopefully that will give you a little bit of an interest, a bit of insight into our audience. So about 50-50 on question number 1.
Yeah.
Most people here tonight are Kizer members, but it's really nice to see that about 20% of our audience tonight isn't a Kizer member. And so a 50-50 on some type of continence symptoms. But exactly as you predicted, Hannah, that more people have not sought help from a clinician despite their continence symptoms. So on that note, I'm going to stop talking about an area in which I don't have a great deal of expertise, and I'm going to hand it over to you, Han. I might just pop up if I've got a question or if the audience has got a question.
Sounds good. Thanks for that, Tim. So firstly, thank you for joining me for tonight. As I mentioned earlier, when I was talking a little bit about my history, this is really an area of personal interest as well as clinical interest for me. More personal since having my own children and having my own sort of issues postpartum. But the main thing I'd really would like everyone to get out of this evening is walk away with hopefully reviewing something that you might already know, or learning something new about pelvic floor function and disorders, and if anything, spark a conversation, because when we look at the research and when we even look at our own poll, unfortunately, people who are experiencing some form of urinary incontinence or pelvic floor dysfunction aren't seeking the help that they probably need. So this is a bit about me. I'm Hannah. I've got a almost 2-year-old at home who my lovely sisters has put in bed for me. I'm not organised enough to get that all done by 7 o'clock myself. I'm physio at Camberwell, and I have some varied experience in working with women's health, and mostly really passionate about safe exercise postpartum, but also safe exercise with pelvic floor dysfunctions. So tonight really is about expanding or refreshing your knowledge. It may or may not, but hopefully will inspire you to start, resume, or continue your pelvic floor exercises. If we can start to raise some more awareness about safe pelvic floor exercise in general, but also as part of any strength training that you do and at Kizer, that would be great. And promoting awareness of pelvic floor dysfunctions in the community. So 1 in 4 Aussies are incontinent, and more than 2 out of those 4 don't talk about it or seek help. There are some interesting statistics in this field. You may have seen this short video before this webinar. Some form of incontinence. Some of you may or may not be surprised to know that actually more than half of those are younger than 50. There is a common myth that incontinence comes with age, but that is not necessarily the case. More than half of those women that do experience incontinence, unfortunately, do not seek help or any professional advice around that incontinence. And there is a large portion of the population that also experience fecal incontinence. So it is a big issue. It's a very important issue because the effect that it has on our quality of life is pretty significant. I'm going to dive straight into the juicy stuff, which is essentially what we're talking about, and that's the pelvic floor. So some of you may or may not have seen pictures or diagrams of your pelvic floor before. This is a side view. So imagine if I was cut right down the middle and standing sort of side on, you'd be able to see my 22-week belly there, and all of my organs. So I'm going to use my mouse to just highlight a couple of things on this. You should be able to see my mouse at home, hopefully. So at the very front, so anterior, I think the front of your body, is your pubic bone at the bottom, that yellow section. So that's that really hard, bony part that you can sort of palpate at the front, very bottom part of your abdomen. And then as you go around the back here, you can see the other bony landmark, which is your tailbone, or otherwise known as your coccyx. Those are two very important points because they're the attachment points of the majority of your pelvic floor. And then you'll see three main organs that exist in the pelvic region for a female. So you have the bladder, which is at the front. That bladder fills with urine and then it empties as it passes through your urethra. And the urethra is this little channel that runs down this way, down to its exit. So that's how we pass urine. Above that, you'll see your uterus. Now, uterus for females is where our womb or our baby grows. So anyone who's had a child before will know that experience of baby getting bigger and bigger and needing to go to the toilet more frequently. That's because it sits directly on top of your bladder and causes it to shrink a bit and not be able to hold as much fluid. Our uterus leads into our vaginal passage. So there is your cervix here, that stretches, dilates, opens, allowed for baby to pass through. And then you have the birthing canal. Behind that is your rectum. So your rectum leads to your larger intestine, which is where we pass feces, through to your rectum and then out to your anal sphincter, which is at the bottom here. You should hopefully be able to see on your screen a bit of a shadow outline here, which shows your pelvic floor muscle. Whoops, just going to go back. Yeah. So your pelvic floor muscle actually wraps around each one of those three openings. And what it does is it helps, when it contracts, it helps to close them off. So it has a direct ability to control our continence. It's part of our active control of our continence. And being a muscle means that we can actually actively change the way it functions if we exercise it, which is where we come in as physiotherapists. The role of our pelvic floor is pretty significant. It supports all three of those organs, so bladder, uterus, and rectum. It helps withstand the increase in intra-abdominal pressure. Now, what that is when we take a deep breath in, or if we hold our breath, your diaphragm pushes downwards, causing increased intra-abdominal pressure in the lower part of your abdominal cavity, which in turn causes a downwards pressure on your pelvic floor. So we need that pelvic floor to work well to actually counteract that pressure. It helps inhibit your bladder muscle. So if we have a really good, strong working pelvic floor, it can tell our bladder muscle to essentially settle down when we need to go to the toilet and get it to quieten off a bit so we can hold on for longer. It helps support during a bowel motion, so we can have that opening and closing of our anal sphincter. It has a sexual sensory function, and it co-contracts with our core muscles for spinal stability. So anyone who experiences lower back pain should be working on their pelvic floor as part of their lower back rehab. Now, unfortunately, I've got a video here to show you and I couldn't get it to work on this slide. So I'm just going to skip over to my other presentation and show you this one. And this was working for me seconds ago and should hopefully show you this video.
The pelvic floor is the base of the group of muscles referred to as your core. These muscles are located in your pelvis. and stretch like a hammock from the pubic bone at the front to the tailbone at the back, and from side to side. They support the bladder, bowel and uterus, and play an important role in bladder and bowel control and sexual function. If your pelvic floor muscles don't work well, you may leak when you do things like coughing, sneezing, lifting, laughing, or exercising. To stop this from happening, you need to switch on your pelvic floor muscles. To switch on the pelvic floor muscles, you need to squeeze and draw in the muscles around your vagina, as if you are trying to stop the flow of urine. Lift them up inside. Breathe normally. Don't hold your breath or tighten your buttocks. Then let go and relax the pelvic floor muscles completely. Notice as you tighten and lift your pelvic floor muscles. They tighten and close around the anal passage, vagina, and urethra. By exercising the pelvic floor regularly, you will train your muscles to work automatically when they are needed.
Perfect. So I was just giggling there because my mum's in the background doing her pelvic floor exercises as I speak, as is my younger sister. So I do have a little bit of a live audience here. Alrighty, so I'm just going to get back into my other presentation now, which is loading. There we go. So that gives you a pretty good demonstration there on how the pelvic floor works. It is really about that contraction and the lifting action that helps support those organs. And that's a very important part when we get into the other end of my presentation. We do talk a lot about exercise and how to exercise your pelvic floor well. And that is an important part of that. So sort of just keep that visualization in the back of your head as we're moving through this presentation.
And I've got a question, and this one's coming directly from me because no one else has found the Q&A function yet.
Yeah.
How separately can your pelvic floor muscles work? So you talked about 3 different areas of it, and this might be, apologies if this is something that you're going to answer later on, but can they work individually? Can you control one area and leave another area relaxed, or can one be problematic and another area be completely fine, or will they just all function together?
They tend to function together as a whole. We tend to train them together as a whole, and I will go into this in a little bit further detail. For the purpose of this evening, we'll look at our pelvic floor working together. When I teach pelvic floor, I actually separate them. So we work a lot on the anterior and then on the posterior, and then bring them together so that you can get the feeling of what a good quality pelvic floor contraction should feel like. Depending on someone's individual needs for pelvic floor exercise, there might be a need to work more anteriorly, so more around the urethra because there's lots of urinary loss, or more posteriorly as a progressive part of training. But in general, we do want the pelvic floor quality of the exercise to be done together as a whole. And the 4 muscles that make up your pelvic floor can't quite work on their own independently. A bit like it's really hard for me to get the long head and the short head of my biceps to work on their own. They work together as I flex and extend my elbow. I hope that answers your question, Tim. So I've had a few questions in the past like, oh, I'd really love for my husband to be able to attend this, or can you make it about men as well? And I don't have a lot of experience in working with men, but I do have a fair bit of experience in working with women, hence why this is more of a women's presentation. And part of the reason why that is because a lot of what I do talk about is menopause and the difference of what we go through as women and as we age, and part of our normal hormonal experience. And lucky us who get to go through menopause as we get to the ripe age of somewhere between 50 and 60, we get all these great benefits that come along with it. So unfortunately, what happens is through the menopausal process, we have some lowering of our estrogen levels. And what that does is it changes or reduces the mucosal lining of the urethra and the bladder. So it changes the way that those two things or those two organs function. We have reduced collagen density. Essentially what that means is our collagen, our connective tissue gets a bit floppier. It doesn't keep its torsion as well as it would if you were, say, 20 or 30. We also have muscle fiber loss with the hormonal changes that we go through. So think of a nice big round juicy piece of steak, and then some of that gets lost as it gets cooked. Essentially that's what happens to our muscles, or can happen to our muscles as we go through menopause. The estrogen affects the receptors in our bladder wall, so it can make them slightly more sensitive, which can make our bladder want to work harder and work more frequently. And there is a slower nerve conduction. So as women, unfortunately, we are in a higher risk group for developing issues with incontinence or issues with our pelvic floor function as we age. But risk is probably the most important word there. It doesn't mean that it's a normal part of aging. It just means that we are at a higher risk of developing issues. Tim, have you got another question for me?
Yeah, Han, I've got a couple of questions that have popped up on the Q&A, and they seem to be an appropriate time to ask them. So, any questions that do go up on the Q&A, we'll keep your name confidential for tonight, just to encourage as many people as possible to feel comfortable to ask questions. And I think there is a function in there where you can make yourself anonymous. But talking about function of the pelvic floor and things that might affect it, one of the questions that we got is if there has been damage to the pelvic floor, say from surgery, can it be rehabilitated?
Yes. So it depends on, again, the individual scenario there. But say we're talking about a muscle that has been damaged, muscle can be rehabilitated. So you'd see, when you're watching AFL and someone has a calf injury, or they might have torn a calf, or they've gone and had hamstring surgery, that muscle can recover with great exercises, as long as they are progressive, timely, and follow all of our exercise rules. So muscle that it can be damaged or affected through surgery or childbirth. Like there might be some of you sitting there going, oh, I've had a tear with childbirth through my pelvic floor. That muscle can be recovered. It may not be the same muscle that was there prior to the damage, but it can still work well with exercise and correct rehab.
It's such a great question, isn't it, Hannah? It's probably one of the only questions tonight that I would have felt qualified in answering, because we need people to understand that your pelvic floor as a muscle is innervated with nerves like every other muscle is in your body, and is made up of muscular tissue like every other muscle in your body. And so for the most part, functions very similar to all other muscles in your body as well. So you have surgery on a hamstring after a football injury. Yes, it will recover. No, it won't be exactly the same as what it was beforehand.
Yeah, you're exactly right. Is there any other probably, Tim?
Yeah, there's a couple more there. We might answer one more and then I'll let you continue on. If you lose weight, does this improve the strength of your pelvic floor, or is weight gain not relevant?
Now, that's a really good question. Weight gain and your overall body weight will affect the function of your pelvic floor. Losing weight will have a positive effect on your ability to the function of your pelvic floor, but losing weight on its own without then doing the strength training for your pelvic floor wouldn't be enough. So the loss of weight would reduce the stress on that muscle and would have a positive effect, but the loss of weight on its own isn't going to make your pelvic floor work brilliantly. You would have to then go and do exercises to improve that function to counteract for that added stress that it's had with that weight that may have been carried for a portion of time. And that's in relation to pregnancy as well. So in pregnancy, as a baby grows, we have anywhere from the weight of your placenta, fluid, and the weight of your baby, about 6 to 7 kilos, plus additional body weight gain that we carry as women, that's a lot of extra pressure on a pelvic floor. So I have women that often I have an assessment with who sort of say, oh, but I had a C-section, so my pelvic floor hasn't been affected. And it's like, well, you still carried a baby for 9 months and you still had that change physiologically to your pelvic floor in that time that puts you at a higher risk than, say, someone who hasn't. That was a great question, whoever asked that. Thank you. All right, we're going to move on now to different types of continence issues that can occur. Now, there are a range of different continence issues that can occur in men and women. These are the most common ones. So I thought it appropriate to talk you through some of the terms that you may have heard thrown around or maybe you have been diagnosed with. The first one being stress incontinence. Stress incontinence is probably the most common form of incontinence that you may have heard of. What this involves is the involuntary loss of urine when there is an increase or added force or pressure. So think of that as like, I cough, I sneeze, I laugh, I run, and I leak. Or I lift something, like I lift a child and I can feel myself leak, or I feel like there's a small amount of loss of urine or a large amount of loss of urine. So that's what stress incontinence is. It involves pressure, or like that increased abdominal pressure I was talking about earlier. Urge incontinence is different. Urge is exactly what it sounds like. It's the urge to go. So it's the involuntary loss of urine with a strong urge to pass urine that you cannot defer for more than 5 minutes. So I should be able to, throughout this presentation, continue to drink water and have my tiny little bladder fill up and go, well, I've got 15 minutes to go, but I can hold on to my bladder. I can defer it and sit this presentation out. Someone who experienced... You've got half
an hour to go, Hannah. How are you going to go over half an hour?
I emptied my bladder just before we started, so I think I'll be right.
Okay, good. Just thought I'd warn you, just in case you thought it was 15 minutes.
At 6:58, I snuck off to the toilet, so...
Yeah, well, just don't leave me in charge of this, okay? So I want you to know there's half an hour to go.
Thank you. Thank you. So that's urge incontinence, and you've probably heard of either, you may yourself, but you may have had a family member who sort of says like, oh God, I've got to go and I've got to go now. And then, lucky us, you can have a mix of the two. So that's when you have stress incontinence and urinary incontinence. So not only do you get some form of leakage that occurs with pressure or increased activity, but you also get the additional increased urge and inability to hold against that urge. So that's what mixed urinary incontinence is. Now, overactive bladder is slightly different. Overactive bladder is when you have all three of the following symptoms. So that's an increase in frequency, so needing to go to the toilet more than 7 times a day. So think of that as, you know, you might have a mum, a sister, or yourself where it's like, oh, I need to go to the toilet every hour and a half. I need to empty my bladder. My husband's a little bit like that when he's had a few too many beers. And there's the nocturia, so that's needing to go to the toilet at night time. Evening toileting is normal to get up and go once. Anything more than once, we classify that as an increase in nighttime frequency. And the urge is associated with overactive bladder as well. So you have frequency, urge incontinence, that inability to defer your bladder, as well as increased nighttime toileting. And we sort of explain this one to patients as the bladder that just fires all the time. I worked with a great women's health physio by the name of Charlotte over in Perth, and the way she explained it to me when I was a student was good. And she always used this hand action, and I'll never forget it. And it was, your bladder just does this. It's doing this all the time. So it's going. You get a tiny bit of fluid in there and it's telling you it's time to empty, and it's 100 mils, where you should be able to hold a good sort of 450 mils. So that's what an overactive bladder can appear like or present like clinically. And then there's bowel incontinence. So that is the lack of ability to control or hold wind, fecal incontinence, and may involve smearing of underwear. So they're the main forms of incontinence that women and men will experience. There are others, but these are the most common ones. So everything I've gone through so far sounds relatively depressing. The most important part of this presentation is what we can do about all of this stuff. So keep calm. We've got great news. Look, we're really, really lucky in Australia. We have had some fantastic research and funds poured into women's health and pelvic floor health. And there are some great, very high quality research papers available to us with huge numbers of participants to prove to us what it is that we should and shouldn't be doing when it comes to the most sort of the most relevant evidence-based practice that we should be following as physiotherapists and as patients. So there's great support that effective and safe management of pelvic floor disorders through pelvic floor muscle training works. The bad news I have is you have to do a lot of it. So this brings me to the next most important part of this presentation.
Now, does it work? Does it work at any age, pelvic floor muscle training?
Now, that's a good question. So this is when individual assessment comes into it, because you can have a 85-year-old woman who is for the first time experiencing some form of incontinence without a very extensive history. For that person, it would be definitely worth giving exercises a go, compared to maybe an 85-year-old woman who has had multiple births, carried twins, potentially had surgery, had pelvic floor issues for a prolonged period of time, tried exercises on and off. She might not have as good an outcome as the first scenario. So it is a bit patient dependent in terms of age, and that is more to do with your history. When it comes to pelvic floor training as a general for all of us, the most important thing is that we have an individual assessment to ensure that training is correct and specific to that individual's ability. So I guess coming back to your question, Tim, it's a really challenging one to answer without having that individual assessment first. The next most important thing is that all of the studies that we have available to us suggest the following. You need a high volume of training. So that means doing 8 to 12 contractions held for up to 10 seconds. Now that 10 seconds there, I want you to take that with a grain of salt, because that is the gold star. Lots of us won't be able to do that with 3 sets. Now 3 sets would be 3 times a day. So you have to do a lot of them across the day. On top of that, you need to do it for an intensive period of time. And this most commonly is, I think, where we get it wrong as patients. When I have historically with my clientele and with patients of mine, probably one of the most common, and I show all of them this slide as part of the consultation, one of the most common feedbacks I get from patients is, oh, I've given pelvic floor exercises a go, I've tried them. And when we talk about, you know, and most of them have done the right thing, but when we talk about how long they've tried them for, often it'll be a couple of months. And then I'll sort of say, well, if we look at the current research that's available to us and best clinical practice, you actually need to do these for 6 to 12 months to see a change in your pelvic floor function. And that's important. The 20-year-old who's got a perfectly working pelvic floor doesn't need to do such an intense amount of training. For someone who's trying to change the function of their pelvic floor, so who may have an issue with the way their pelvic floor is working, they need to do the exercises for a prolonged period of time. So I really would love you to all take that message home with you. And the other most important thing, and for me as a physio, this is like the number one, exercises require progression. So for us to have a change in the way our pelvic floor functions, not only do we need to follow these guidelines around how many we need to do, how long we need to do them for, and for what period of time, we need to make sure that the exercises are progressive. Because if we do the same thing over and over again, that muscle actually won't improve or change. So anyone who works, who trains at Kizer, which was about 80% of our viewers tonight, it would be like me setting you up on one of our machines on a certain weight and then saying, you do that same weight for the next 12 months and you'll get stronger. That would be an absolute lie. You need to have progression in your weights, whether it be weights or timing, for you to see a change in the way that muscles work or the way a muscle would function. And in turn, get more strength. So it is important when you're doing this that we do have progression, and there's lots of ways that we can progress pelvic floor exercises. So how do the exercises work? So pelvic floor muscle training works in a way that, just like when we work any muscle, if we strengthen a muscle or exercise a muscle, it increases in size. So if I do lots and lots of bicep curls, that bicep's going to get a little bit more tone and it's going to get stronger. The fibers will increase in size, and in turn, it will get more tone or more stiffness. Pelvic floor is the same. When we have a stronger pelvic floor muscle, then we have less bladder and vaginal opening. So what that means for us is our urethra will have more active control of how much it closes. So when we need to go to the toilet or we're busting to go and we think, oh, I need to hold this, or I need to cough and sneeze against a lot of force, then we have the ability to close that down. Stronger pelvic floor muscles, when we do these exercises, it helps lift the position of the rectum and the bladder. And one of the things I haven't spoken about a lot tonight, and I won't go into in detail, is prolapse. The reason why I haven't done that is because there are so many different forms, but pelvic floor exercises can help the position of our organs. So for someone who might be experiencing something like a prolapse, that can help lift that organ position. It takes a stretch off the muscles, it reduces the downward pressure from the intra-abdominal pressure that we talked about earlier, and it improves our skill of pelvic floor activation. So these exercises hold a lot of weight, I think. Off you go, Tim, you got a question?
That was a good pun, and well done. I feel like you're setting yourself up for a sequel by saying that you're not talking about prolapse tonight. So I'm looking forward to being part of the sequel. Hopefully you have me back as MC again. One of the questions that we've had, and is really important in pelvic floor muscle training, is the relationship that it has with back pain. I was wondering if there's one of these points here that was most relevant, or perhaps you might be talking about back pain a little bit later.
Back pain I don't go into a lot with this. I do a bit when we talk about Kizer specific. But yeah, so pelvic floor, there's some interesting research to show whether or not pelvic floor retraining actually improves your back pain. But what we do see that when we have a stronger pelvic floor, a better functioning pelvic floor, you also have better co-contraction of all of your core muscles. So involving your transverse abdominals that runs across the front, which is a really important muscle for pelvic floor support, and some of our deep multifidi. So most of the research suggests that if you have a stronger pelvic floor, then you will also have a better ability to contract and isolate those other core muscles. So in turn has a direct relationship in how we can manage our back pain or manage our lower back weakness. Yeah,
that makes sense. And it also sounds like you've set up for a third one there. So one on back pain and one on prolapse as well. We've got a whole bunch of other questions here, yep, Hannah, but I don't think any of them specifically fit onto this slide. So I might get out of your way and let you progress through. But we're going to have quite a few to answer in the last 10 minutes for sure.
All right, I'll speed through this last part of the presentation. This is going to be interesting because I've never done a practical element of any presentation via a webinar. And this is normally when I would walk around a room and have a look at everyone trying to do a pelvic floor exercise. So in the privacy of your own homes tonight, you've got the ability to try a pelvic floor exercise. I do want to point out these two pictures. When we do a pelvic floor exercise, I've talked a bit about intra-abdominal pressure and what that means for us. On the first slide here, you can see this is breathing easily. So, someone's got a nice relaxed sort of breathing. They're not holding their breath. what that allows is the bottom of our diaphragm here to also be relaxed and not be pushed downwards, which gives our pelvic floor at the bottom a better chance to resist against that pressure and actually contract and come upwards. So when we're doing pelvic floors exercises, you may have had a physio or a friend or a healthcare professional talk about the importance of not breath holding. That's what they're talking about. Because when we look over at the other picture here, we can see if we're holding our breath, that diaphragm comes down lower, therefore takes up some of that space in that cavity, and it makes it harder for your pelvic floor to contract upwards. It's probably one of the easiest things for us to self-assess when we're doing a pelvic floor exercise, whether or not we're holding our breath at the same time. So let's try the prac and see how it goes. But I always teach this with your eyes closed. I find with your eyes closed, it just gives you that little bit extra ability to concentrate on what you're doing. So
turn my video on, Han, and I'm going to participate. Just
good.
So I
won't close my eyes through this, but
so you've got someone to look at and make sure the crowd's participating. So where do I start? What do I do?
All right. Well, firstly, when I say vagina, I'm talking about your penile function. So can you just keep that in mind when we go through this too?
Yeah.
Perfect.
Okay.
All right.
Noted. Thanks, Hannah.
Everyone, have a look at how Tim's blushing right now, and then close your eyes. So I'd like you all to firstly get yourself in a really comfortable sitting position. Our posture when we do pelvic floor exercises is very important. So we should have our feet separated on the floor or in a standing position if you're standing like Tim. Standing is harder because it involves a lot more gravity. Thanks, Tim. Sitting up nice and tall in a comfortable posture for you, all right? As part of an assessment, we can look at postural changes, but for now, I just want you to feel comfortable in sitting. With your eyes closed, I want you to connect with what's called your perineum. Now, your perineum is essentially that whole area that we're talking about around your pelvic floor. So when I'm sitting, I can actually feel my perineum sitting or resting against my underwear or against the chair beneath me. So try and connect with that area as best you can. The thing you can do, because you're at home on your own, is if you can't figure out where it is, put your hand there. No one can see you. I really can't see you at home, just in case you're nervous about that. All right, so now you can all stop laughing and get that normal breathing happening. And just take a slow, nice, deep breath in and out. And then after doing that deep breath in and out, return to a normal breathing pattern. So just how you would breathe naturally. We're going to start with working on the front part of your pelvic floor. So when we're doing this squeezing sensation, trying to get our muscles to contract around our vagina or our urethra or our penis, as Tim is, I want you to think about stopping the flow of urine. So just focus on that. What would it feel like if I desperately needed to pass urine and I'm trying to stop that from happening? So think about squeezing around the front. You can just squeeze and let go. Give that a couple of goes. Take note on what your breath is doing. And think about how that felt. Because now we're going to go around to the other end of your pelvic floor and focus on the posterior aspect around your anal sphincter. So same thing, same position, same relaxed breathing. Now I want you to imagine that you're trying to stop the flow or the passing of wind. So it should feel like a very gentle, subtle squeeze around your anal sphincter. You shouldn't feel your bottom muscles squeezing together, and you shouldn't feel yourself holding your breath. It should just feel like a very gentle squeezing sensation. Think about how that felt. Now I want you to relax, and we're going to practice bringing both areas together. So when you feel ready, on the next time you give this a go, you're going to really bring the feeling of stopping urine and wind at the same time. So you should feel a gentle contraction of the muscles from the front all the way around to the back. And that should feel different. It should feel stronger than when you try and separate them. Now, the reason why that's important is you go back to that very first couple of slides I showed you on that video, you will have noticed the span of, or the cross-sectional area of the muscles in the pelvic floor, quite a large amount of that sits around the anal sphincter. So if we're just focusing on the anterior portion, we're missing out on a lot of that muscle fiber contraction at the back, and we're not going to get as good a result as if we're working them all as one. Hopefully you could feel something. If you can't, that's okay. Some of you might be doing this for the very first time. And that's when we'll sort of go into further information on where you can access it. Thanks everyone for giving that a go at home. And thank you, Tim, for participating. That was very kind of you.
No, I haven't taken a breath for the last 4.5 minutes. So I think that says I've got a fair bit of work to do.
You need work, Tim. We can do a telehealth session later this week.
I'm committed to giving it a go, Hannah.
Good. All right. So look, I'm getting towards the end of this now, and I did want to sort of talk a bit about what we do at Kizer, because a lot of you are doing training at Kizer, and a lot of you may be using the A5 machine. Now, I'm a big lover of the A5. Often for a lot of my patients, this is the goal. This is like, get me on the A5, and we might work for months on your pelvic floor strength until you're good enough to get on the machine. It is such a good tool because it promotes regularity, because you're going to do it. Because you're coming in, you're doing your training 2 or 3 times a week. That's 2 or 3 times a week. At least we know you're definitely getting your pelvic floor exercises done. It's an awesome visual tool because it gives you this feedback. So sometimes we can be sitting there going, far out, I don't freaking know if I'm doing a pelvic floor exercise. At least it gives you some kind of sensory input and external feedback by the patterns and lines that you can follow on the screen. And it's progressive. We talked about how important it is when you are exercising a muscle that you actually progress those exercises to see a change. And the A5 does that through the programs. The thing we need to keep in mind is the quality of your exercise really matters. And there are lots and lots of ways to do a pelvic floor exercise wrong, just like there are lots of ways to do a leg press wrong. So when we are doing that A5 machine, it is really important that you have correct activation of your pelvic floor. I find that like you'll notice this, and you could even give it a go next time you're on the machine, but the sensor is incredibly sensitive. It will sense if you're squeezing your bum muscles together, it will sense that. So it is important when you do the A5. I find myself, if I've worked a full shift as a physio and I've been on my feet and I do the A5 after a shift, my pelvic floor is rubbish. Can barely switch the thing on. If I do it at the beginning of my shift, I perform very well on the A5 because I haven't been on my feet all day and I haven't had gravity working against my pelvic floor. I also find with lots of women and men that when you do the A5 matters. So if you're someone with pelvic floor weakness or a change in your pelvic floor function, you might be best to do your A5 at the beginning of your program when you're less fatigued, compared to doing it at the end of your program when you're absolutely buggered, you're ready to get out the door and you're thinking about the next thing that comes after Kizer, not fully concentrating on what you're doing on the A5 machine. So there's
which is very true of all exercises when we're taking someone through rehab, isn't it, Han? Like if we're rehabbing a knee or rehabbing an ankle, we'll always try and put those exercises at the front of someone's program because they can concentrate more and their central nervous system isn't fatigued. So in a difficult exercise, they're able to get the technique, which is what you're saying, that everything in pelvic floor training comes down to technique, doesn't it?
Yeah, exactly. You're exactly right. And I think for me personally, and maybe it's because I work at Kizer, but I have had this feedback from other members, but you know, if you leave it to the end, your last exercise, you're thinking, I'm ready to go now. Like I've got to go to the groceries, I'm going to go pick my kid up. I'm not going to concentrate on the A5. So do it first and you'll probably have a much better outcome. And probably the number one thing that I see on this machine is someone who gets on the A5 and they're like, I don't have a pelvic floor. I don't have one. I've just got this flat line and nothing's working. And it's probably because you actually haven't set yourself up well to begin with. So posture is important. We've set you up in a particular posture on the A5. If you're having trouble on the machine, first thing you should do is to straighten up, get yourself in a good position, Make sure your feet are underneath your knees, and sit up nice and tall, wiggle your bottom backwards, have really good support behind your back with the backrest, and then try again. And if you're still having issues, talk to someone. We've got all this stuff available to us, whether we're in session or not. Grab someone, say, hey, I'm having trouble with this, and then we'll go, all right, I can come give you a hand now, or sorry, I'm actually with someone, but let's book you in and we'll go through this machine one-on-one. So very important message there with the A5. The other things we need to consider when we're doing not only Kizer training, but any kind of strength training. So this might be training you do at your own gym. It might be boot camps you're involved in at the moment. We're all in isolation, trying to get fit, throwing tires around. Please don't do that. But what we can find is that with certain exercises, we breath hold. So if we're working really hard, if we're lifting something heavy, then we can tend to hold our breath. And if we go back to everything we've spoken about tonight, breath holding really increases your intra-abdominal pressure, which puts pressure on your pelvic floor, which is not going to help it function well. So if we're doing any form of strength training or weightlifting, high intense exercises, then we should think about that relaxed breathing as we're doing it. So I train most of my women clients with pelvic floor dysfunctions. If they're on something like the leg press, which is the B6, which is both legs pushing out together, we breathe out with pushing phase. I push with my muscles, I breathe out, and that will help reduce your intra-abdominal pressure. Same with the lumbar extension machine. So that's the back machine where we're moving backwards. I push backwards, I breathe outwards. A2, I'm pulling up the challenging part of an abdominal exercise. I breathe out as I bring my knees to my chest. Abdominal crunch, or the F2.1, seated abdominal curl. I breathe out as I curl down. Almost every exercise changes your intra-abdominal pressure in some way. Running does it, walking does it, laughing does it, lifting something does it. So it is really important to apply correct breathing pattern, and you can either do pelvic floor prep. Now this is for someone who might have really high functioning pelvic floor or have a really good handle on how to do a pelvic floor exercise. You can do something that you know is challenging and do your pelvic floor exercise at the same time. I don't encourage that for anyone that I haven't seen, but if you know yourself that you've got a great working pelvic floor, then feel free to try that. Rightio, so you have listened to me for quite some time now. So I want to wrap this up before we get to some questions, because I know you've probably got heaps of questions for me. But really the take-home message for tonight is that incontinence and pelvic floor dysfunction is common. It's not a normal part of us though. It's not, we shouldn't accept it as something that we have to live with and it's a life sentence, because it's not. Most of this can be managed, or most issues can actually be managed well with conservative measures. The conservative measures are the exercises. They give us great results, but you've got to do them, and you've got to do them regularly if you're going to expect them to have an effect. I wouldn't do a rehab program for chronic lower back pain and expect that I would have a great back in 12 months. I've got chronic lower back pain. My back's going to give me issues for a very long time. It is a life maintenance program, as is the pelvic floor work. I really would love to start a conversation. You might walk away tonight and have the confidence to have a conversation with someone, be it your sister, your mother, your brother, your husband, your GP, your physio. That would be great. But don't be afraid to talk about it, because it is a common issue that many of us suffer in silence with. There's an awesome amount of clinical evidence out there and lots of resources available to us. In Australia, we have a ton. So we've got all these resources for further information. Tim will send this to you tomorrow in an email. And with that is a questionnaire.
Unless I'm busy still doing my pelvic floor exercises.
Oh yeah, that might take up a whole 3 minutes of your day, by the way. 3 minutes takes to dedicate to those exercises.
I'm halfway through A5 as we speak.
There you are.
Shifted sets.
Oh, multitasking. I bet you there's lots of breath holding going on there, Tim. So Pelvic Floor First has a great screening tool. Tim will attach this to the email tomorrow. It is for your own personal use, but we use this as healthcare professionals quite frequently, and it can highlight to yourself whether or not you need to seek further help. So if you answer yes to any of those questions, we recommend that you seek help with your healthcare professional. So women's health physiotherapist or physiotherapist like myself, who's got a specialist interest and experience in this area. And there's multiple other resources there that you can use. So Tim, I've gone over. I'm sorry.
No, not at all. Not at all. Everyone's really excited and they've got lots of questions for you. So first one, which came from one of our listeners, but also I got a text message midway through from one of our team who suggested this is pretty common. I'm 60. I don't have any pelvic floor issues. Should I start these exercises?
Yes. Absolutely. Did you see my slide on menopause? Yeah.
So preventatively, it is important.
Preventatively, it's important. But again, as a woman, particularly if you're 60, one of the most important things there is that we are at a higher risk of issues with our pelvic floor. And if we work on it before we have a problem, then we are more likely to make a change. Someone who doesn't have a pelvic floor issue doesn't have to go away and do 3 lots of 12 every single day. That person can get away with less frequent exercise to maintain and build strength. So your program would look different to someone who has a pelvic floor dysfunction. Okay,
and if I'm doing these exercises, is there only one exercise that I need to do, Hannah?
No, there's multiple. So 2 different types of exercises that you would be taught. One would be a quick contraction, so that works the fast twitch fibers of your muscle, and one would be a slower contraction, which involves a hold. They're working more on your endurance. So you think, I want to hold on to a wee, I need to be able to hold my pelvic floor for a prolonged period of time. So there's different types of exercises, and then the progressions involve positional changes. So laying, no gravity, no organ weight. Sitting, we're adding in organ weight. Standing, more gravity and organ weight. Someone who's a runner, I would want to progress them to being able to contract whilst they're running. That would be like the very end goal. But it does, there's multiple different ways to progress and different ways you need to do these exercises.
And about 50% of our crowd, when we asked the poll at the start, had a child, but I'm sure there's at least one listener aside from yourself who is currently pregnant. So pelvic floor exercises before pregnancy and during pregnancy, as opposed to just after pregnancy?
Very important to do pre and during pregnancy. The important thing that when we're doing pelvic floor exercises throughout pregnancy is that you can build your muscle size, like fiber size, and control, which puts you in a better position to be able to do them well and have a better functioning pelvic floor after. A stronger muscle will have a greater likelihood to stretch and withhold increased pressure without injury. So it can reduce your risk of pelvic floor tearing or injury through delivery. And preemptively, I encourage all of my friends to do pelvic floor exercises pre-pregnancy. But great to do throughout pregnancy. The thing is that when we get to a certain point in our pregnancy, we won't progress, but we want to maintain.
And that's the same message that we're using for pregnant women when we're talking about other injuries as well, isn't it? Like in terms of preventing back pain during pregnancy, which is a really common problem during pregnancy, or someone who's going into it with an existing shoulder or neck injury or something like that. The advice is really consistent. We really shouldn't treat the pelvic floor any different, should we?
No. If you want a really good functioning, strong body that is got a low risk of injury, then you would exercise regularly and partake in strength training to make sure that your muscles have the ability to change and withhold force and operate in the best way that they can. Pelvic floor is a muscle, so it is exactly the same.
And the type of incontinence that I have, does that influence which exercises that I should do, or whether I should contract fast or slow, Hannah?
Yes, it can. So the program that would be designed for someone, say, who has stress incontinence, that may be say, for instance, involve a lot of quick contractions against force, practicing against force compared, plus your slow contractions, but there might be a larger focus on one type of exercise compared to someone who might have a problem holding, who might need more endurance in their pelvic floor. So that, yes, there can be differences in the prescription. The most important thing is to have an assessment. There was a really interesting study released that showed that most women who had trialed pelvic floor exercises before did them poorly. So even if you sort of think, well, I think I'm doing pretty well, but I don't know, it's always worth just having a one-off assessment for a healthcare professional to look at you do them, palpate you doing them. It doesn't have to involve an internal. There's so much we can do externally to make it more comfortable for our clients, and make sure that you're getting the best out of your exercises so that you will be one of those people who benefits from pelvic floor exercises.
I guess that's and just another consistent theme, isn't it? I mean, that's something that we say to all of our clients that, yeah, I mean, you can go and Google pelvic floor exercises on the internet. You can go and Google knee rehab on the internet, but it's this supervision and it's the subtleties and the nuances of getting your technique right that will make a difference to your results down the track, isn't it? People are just so much better off coming to see you or seeing a pelvic floor physio than trying to do it themselves.
Yeah, absolutely. I think if in doubt, I would always seek healthcare professional advice. I wouldn't manage my own back pain at home, and I wouldn't trust Google to either. So pelvic floor needs to be treated in the same way.
And a couple more questions. There's one regarding endometriosis and the relationship with pelvic floor muscles. I just picked that one out. We're probably not going to be able to get to all of the questions, but I know that's a particularly it's been in the news a lot more recently, and awareness of that is kind of increasing. So is there any effect or relationship?
To be honest, I haven't read anything recent on that. So I wouldn't want to comment on that, but I can definitely, if that person wants to send through their details, I can send their details to me, Tim, and I can do some research and find out some further information. It depends on what we're talking about there. If we're talking about a change in pain, or if we're talking about a change in the way it affects the quality of life. There's lots of different types of ways endometriosis can affect people individually, and severities of it as well. Yeah. I'd need some further information to answer that.
Okay. There's a couple of other questions around specific conditions, so I won't ask those, but what I will do is, Hannah's put an email up here because one of the themes for us in these Kizer on the Couch sessions is that we want to give people some practical advice and guide them in the right direction. And so if there's a lingering question where we haven't quite guided you in the right direction, then get in contact with us, get in contact with Hannah directly, and we will do what we can. We can't provide a consultation via email, but if what you need is a consultation, then we can organise that. So last question for the evening. Do you have any opinions or comments about devices marketed for assisting with pelvic floor training, like the Epino, the Alvi, and the Mediballs? And I know the person who wrote those questions, and I'm actually not sure if she's taking the mickey out of me or if they're legitimate ones, but I promise
they are legitimate ones.
I promise all I've done is just read the question, Hannah.
Yeah, no. So there are lots of different things on the market available to you. Again, if you're going to use them, you are best to be guided by a healthcare professional first. So if we talk about something like a Mediball, or a lot of you may have heard of the Kegel balls. So they are small balls that you can actually insert inside your vagina and use your pelvic floor to hold them in place. So it's a form of resistance-based training. There is interesting, like some good evidence behind it. But again, they need to be used in the right way. So that's when it comes down to that sort of individual assessment. The others, like there's just lots of different brand names for all these types of sort of modalities that are available on the internet. I just can't stress enough how important it is that if you're going to use something like that, that you've either been recommended by a women's health physio to do so, or gynecologist, and guided by them how to use it.
Thank you so much, Hannah. And on behalf of everyone who's signed in for this evening, thank you for all of your expertise and what's clearly a passion for you and a love of this topic. Thanks for teaching me a lot tonight and making me feel relatively comfortable with all of those words that normally I wouldn't say without giggling. For everybody who came along tonight, we will send out an email with all of these resources to you tomorrow, including contact details if you would like to ask another question. And we know that this is a really popular topic, so hopefully you enjoyed it. Hopefully you can share the video with your friends. But we've just got one more poll to finish on, which is to help give us a bit of an idea about what topic we might talk about next time. So Carlo's going to pop that poll up, and then we'll leave that up for a couple of minutes. And other than that, thank you very much for coming along. Everyone, stay safe, keep yourself physically active, and keep talking about pelvic floor and continence, because it is something that can be trained and can be treated and shouldn't just be ignored or accepted. Hopefully there's a way we can help you all.
Good stuff. Thank you so much, Tim. And thanks everyone for joining me. Might be in contact with some of you soon.
Thank you, Hannah. And on behalf of everyone, good luck in the next couple of months of your pregnancy as well. I'm sure it'll be really easy. No problems.
Breeze. It's fine.
I feel like I heard a giggle in the background there.
Yeah, that's my sister. She's going, oh, man.
How many kids has your sister got?
None.
None. Oh, we're equally qualified then.
You're equally qualified. She's a very experienced auntie.
Okay, well, maybe she is more qualified than me. Carlo, how are we going with the poll? Have we had most people answer that question? Carlo doesn't. 91% of people answer. So, well, we might call it a day there. Thanks again, Han. Thanks everyone for coming. Go to kizer.com.au/webinars if you'd like to see what our next topic is. And I look forward to making contact with you all again soon. Thank you very much.
See ya.